great set. What a great and interesting and diverse set of panelists. We have about 20 minutes, 23 minutes for questions. And so if you line up at the microphones and start by introducing yourself, and we'll poke into the interesting aspects that we've heard about. So here, Paula.
Great. Thank you all so much. What a terrific panel. And there's so much food for thought here. I do want to ask Lisa a question. So on its face, trying to incentivize researchers to do work that has impact is intuitively very, very appealing to me. But I also worry about incentives can have perverse effects sometimes too. So I worry in some, especially thinking about academia, incentivizing this might make people go more for the low-hanging fruit, the easy wins, and then steer away from some of the issues that we deeply care about in public health, like issues like racism and structured chance and the more complex and sometimes seemingly intractable issues. So I don't know if you want to speak to that.
A really important point. So I think that this is one reason that maybe it's a good thing that we're lagging behind other countries, so we can look at what lessons they learn and what unintended consequences occur. The REF, the UK REF, as I mentioned, they're doing a number of analyses to look at its impact, and they do this every 5 years, and they're going to be revising it. So I think there's an opportunity to look at, see when and how did those unintended consequences occur, in which departments, those kinds of dimensions. But I think it's also part of the reason that only 20% of the score was linked to impact, recognizing broader research, the traditional ways we measure science and contribute, academic impact. So I do think as we think about it in the population health frame, we need to be cautious. But I don't do the work that I do trying to translate research into policy if I wasn't committed to, gosh, we have so much science already sitting on the books, we gotta use it, guys. So any change in this direction, I think, will be positive, and we need to mitigate or manage the negatives.
Okay, thank you for that. We have a couple of people lined up here. Introduce yourself, please.
Hi, Laura Herrera-Scott. I used to be a state public health official, and so I was a user of the research. And I will say we were often approached for letters of support by the researchers, but there was no collaboration. And after the grants were awarded, no then tie back to a state health department and efforts that the state was trying to do, often on the same initiatives. And in my world, I could have imagined how much more of an impact we each could have had working together. Can you speak to that a little bit about researchers engaging with state and local public health officials?
Sure, and I speak to this both as a researcher and a former state health MCH director, so I've kind of lived on both sides. That is very much the case now, that researchers are not, again, it's not the culture of research to go out and develop the questions with the end user. I do think that's changing. Again, small steps, but the focus from certainly the Robert Wood Johnson Foundation on working in PHSR, Public Health Services Research. Again, that's a program that we've worked with colleagues at the University of Kentucky and others in to really try to get evidence relevant and developed with the users. I think the whole push towards CBPR, community-based participatory research, again, has been a move in the right direction. But I keep coming back to, until that type of research is rewarded, and researchers can get promotion and tenure and get published and get money that actually pays for the full cost of doing that engagement, it's going to be very limited. And I haven't seen that major shift in the funding.
Any other panelists want to speak to that? Yes.
I want to echo the importance of the partnership, but I guess I would just say that in some ways this can be a false dichotomy. In a lot of cases, there are kinds of data we can only get as researchers in partnership with outside partners like public health agencies. They're the ones who could, for instance, randomize the treatment that is otherwise impossible for us to administer, or at least administer in a way that would allow us to estimate the causal effects of that treatment. So in a lot of cases, I think the incentives are actually changing in the opposite direction. I'm certainly seeing this in the social sciences, where partnerships are very highly valued now because they offer these opportunities that are otherwise impossible. So I do think the trend is positive here.
And just briefly to add too, I think two things we're also seeing is the private sector sometimes stepping into exactly the role that Lisa's bringing up. Sid and Helene Lerner have started now 3 learner centers for public health promotion at Syracuse, Columbia, and now Hopkins. And the purpose of those centers is to try and take research that we have and move it into the field and make a difference. And the idea is to try to activate moving that forward. And Mr. Lerner comes from an advertising background where everything is about sort of moving quickly and moving things into action. And also, too, just to say, I think in our appointments and promotions process now at Hopkins, faculty can have a practice portfolio and try and describe in a narrative way who did what with the research that they produced, whether it's health departments or policymakers or others. So, thanks.
Okay, thank you. We got a good lineup already, maybe more than we'll get to. You were next, I believe, so go ahead, and then we'll go over to the other side.
Thank you all for your excellent presentations. I'm
Yeah.
Ellen Beck-Jord from the UPMC Health Plan, and my question is for Brendan. I was wondering if you could comment on how the rapidly evolving information environment, including social media, even things like citizen science, more technology-mediated social participation. We could talk for the rest of the day about that, but how has it affected your work specifically? And has it had an effect on the way that people are thinking about either some of the theories or constructs within communication? Are new ones emerging? Are old ones being revised? Things like that.
So that's a great question. It's one of the questions I get asked most often. I guess what I would say is I'm cautiously skeptical so far, and let me tell you why. The evidence suggests that people have believed in conspiracy theories and misinformation of various kinds for, as long as there have been human beings. And so Twitter and social media surface some of those things and make them more visible to us in lots of ways, but they're reflecting things that were moving through other channels of communication in the past, in a lot of cases. Now, that doesn't mean that the speed of these myths hasn't changed. I think it's fair to say it has, and we've certainly gone through a very rapid boom-bust cycle of people thinking we can get information to people that will change all their minds even more efficiently than ever before, and then moving from that to a kind of super pessimistic view that it's just all misinformation and nonsense, and how can we ever counter it? So I guess I would just say, you're right, we could talk about it all day, but I guess my perspective is to say we should think about this in the larger context of what we know about how people process information. The one other thing I would just say is most people actually don't care enough to go look at almost any of these issues in depth online, right? So most normal people don't go read about whether Obama was born in this country or death panels or whether 9/11 was an inside job or vaccines are unsafe on a daily basis, right? That's an unusual person, right? But for those people, that information is now at their fingertips. So if they do want to find information to support some pre-existing view, it's out there. And I think we do have to take that seriously because in some cases, those are the people we care about the most.
Okay, thank you. Over here.
Jean McGuire with Northeastern University, and great panel, and cautionary tales are always important. I wanted to focus on David and then see if other people wanted to comment. And first of all, I didn't want people to walk out of here and say, David said drugs don't matter, because of course there's more to the story than that. But you have this advantage of improved modeling and long history to look back. So maybe the articulation of the social behavioral analytic work in the early 80s is better constructed as you're looking back at it now. But what it says to me, and I think it was something that was true, is that there was a lot of learning and doing that was co-occurring, and that was somewhat relying on extending research from prior findings, applying it, and continuing to go after reducing deaths, a single focus there. I sort of feel like, population health, we're not looking at an AIDS epidemic, the kind of mortality at the moment, but we are in a kind of broader way. And if we thought of this time as a time that's crucial to learn and do, because there's a value-based purchasing opportunity to maybe get some savings and other sector interests, perhaps there's a corollary. So what's the lesson from the learning and doing and moving it ahead, and the risks of moving ahead something that may not work, may add to the myth, may be a bad finding because you asked the wrong question?
Yeah, so David, and then maybe other panelists want to join in on that?
Great. Thanks, Jean, for the great question. And I agree with you. The title of the paper you mentioned was Causes of the Decline in AIDS Deaths, Prevention, Treatment, or Both, and the punchline was both. So I appreciate the opportunity to clarify that. And I think what drugs did was take a curve that would have been going down anyway and rapidly accelerating the speed with which that went down. I think one of your point about learning and doing, I think one of the reasons I'm excited about first the national strategy in 2010 and the updated strategy is I think we now have entered an era in HIV where we're much more focused on explicit metrics. And because of that, we're able to sort of manage to that outcome and it's helpful to manage to process, but I think it's even more important to manage to outcome. And we can sort of look at, are we making a difference in meeting those diagnoses goals and those access to treatment goals? And if what we're doing doesn't work, we have to keep experimenting and try and find different ways that do that. So I agree. And and I guess the quote I just wanted that came to mind as you were speaking was Bill Foege recently, or now it's been a little while, visited Hopkins, and somebody asked him, should researchers advocate? And he said yes. And then they said, how far should we go? And he said, the line is the truth. And I've really liked that a lot, and I think it applies to some of the things we're talking about in HIV.
Anybody else want to
I just
chime in
wanted
on
to,
that, Lisa?
Say that I'm very pleased you brought up the issue of de-implementation, of how do we not do, when things are not working, how do we get rid of them? Because that is, in the overall science of dissemination and implementation in health, we're now starting to see more of a focus on that. And in the policy context, unfortunately, it's really challenging because once a policy is passed, going back in and trying to reverse that is often very difficult. And so the stakes are high that you want to be sure you know that truth before you implement.
Yeah, Maya?
And on the housing side of things, it's where you live, both your actual home and the neighborhood. It's quite hard to change the policies around it and to change any of these aspects of locations. And thinking about the research aspect too, I just want to clarify the value of the funders and the incentives in trying to change at least our application of research. And there's still being challenges there. I mean, the MacArthur Foundation, for all of their How Housing Matters grantees, they're required to try to get the research to have policy relevance. Yet, in anonymous conversations, many of them still say, my job is to look for the truth, not to change anything. And so trying to figure out the incentives that actually get us to say, we know enough to do a little better now, and then we should continue trying to learn and doing better. And then, what do we actually do to be able to change what we know to be, poor models in public housing in a way that actually creates great opportunities for people, that the people who are affected are part of the process of the change, but the research base is also part of the change process too.
Okay, thank you. We have 3 questions in 10 minutes, so we can get to everybody probably. If we're succinct, you're next.
I'll try to be quick.
Okay.
I'm Nana Bennett. I'm from the University of Rochester, CTSI, where we focus explicitly on population health improvement, which makes us a little bit different from some of the others. I was also the senior author on the Szilagyi paper, so I appreciate your mentioning it. But I also wanted to point out that there was a companion article in that particular issue written by Mark Gorovich that was about why academic centers should be focused on population health and why the time is really right. And Mark laid it out totally beautifully, I think. My question, though, is as we are focusing on population health and as we are focusing on changing our institution and also changing our CTSI, one of the explicit recommendations in the IOM report on the CTSAs was to really engage the community across the research spectrum. And while we're working very hard at that end of trying to prove that research has some impact on community health, it gets much more difficult as you move back the spectrum. And I wondered if you had any thoughts about that, and also if the instruments that you've mentioned, which actually I don't think the CTSA network is aware of because we're struggling with this so much, I wondered if they in any way address this issue also.
I think it's a huge struggle. I sit on the External Advisory Committee of another CTSA, and while as you mentioned the CTSA network as one example of information sharing, I just don't think we know about what others are learning and where progress is being made, and that's really slowing replication or additional learning. I mean, David just mentioned, in his talk about the practice portfolio. I think there's a lot of opportunity to learn from each other where there is progress. But I can't say enough how hard this is. And again, until the money follows, the money follows the person. That was another demonstration program in welfare. Until the money follows this priority, it's going to be very limited. But I want to make a comment that we talk here in generalities of the academy and institutions and academics. It's important to realize that we don't want I don't think we want every researcher to become somebody who cares about application, because that's going to harm new knowledge, discovery. There needs to be connection, but there needs to be room in academics that whatever your passion is, you can be rewarded for doing that excellently. And right now, there isn't enough room for those who want to translate and have an impact. So I don't want to make people think that it's one size fits all in science.
Okay, thank you. We have 2 more questions, so go ahead.
I'm Jerry Fairbrother, a consultant with Academy Health, and I wanted to. I'm also talking about the issue of translation. That you and I, Lisa, have been associated with demonstration programs with CMS, and where the assumption seems to be if you demonstrate it, people will pick it up, or if you package an innovation and archive it in the Innovations Exchange, people will pick it up. And I'm wondering if there needs to be more explicit funding in the translation. I mean, more thought about how that should happen, and actual funding. I mean, most of the I am pretty serious about translation, and it's been hard to carve money out of a research grant for the dissemination part. So how we do dissemination writ broadly, I think and translation in particular, and who does it? Is it the researcher who cares about truth, and that's legitimate, or is it somebody else, and how do we reward it? I think we're doing thinking, but the funding part, we may need to do more thinking, and like, what does it take to get out to get the results out? And I'm reminded of your slide with this slide, that policymakers really do hope that, in my experience, hope that if you fund something, demonstrate it, people will come. And maybe that's just not so.
Okay, any brief panel comments on this?
Well, just very briefly, I think there's also I agree with the point, and that there can be investment in research in how best to do that translation. Jeff Kelly and Medical College of Wisconsin did a trial once on moving HIV prevention into the field, and looked at documents in training, training, and hotlines. And not surprisingly, more was better, but it provided important insights for how to best do it and make that translation work as well. So it's another kind of investment, I think.
Okay, last question from our keynote, Nancy.
So thank you very much for this panel. I think you all touched on many topics that are of concern to all of us here. And I have a comment and then a question. So the comment is more the need for, which comes across in the different things you say, but the need to always tie not just population health as such, but health equity. Because what happens with each of the different examples that you're talking about is that the health equity component can easily be overlooked in the name of approaching population health and trying to understand the impact on population health. So, for example, the presentation that you gave on HIV was incredibly informative, and yet we also know there's different epidemics that are happening in this country, and they're not all playing out in the same way. So not to understand what's been still happening with the AIDS epidemic, for example, among African Americans, is really, really important to understand where we look and what's important, but then also how do things change and how quickly. A lot of the work that I've seen that's on impact won't change quickly. Well, we know that public health problems, and this is where I think also the part of the population health perspective is so important, and you touched on this in one of your last slides, Lisa, was on what's the time scale? What's the difference between a fast-acting drug or a vaccine versus something that takes a lot longer in terms of what it takes to even get diabetes, let alone turn it around? So if we don't bring that kind of thinking to this question of impact, we'll be actually very harmed by saying that it has to be incentivized to impact. And I have colleagues in the UK that are social epidemiologists who are commenting on what they have had to go through, and a very narrow interpretation that impact is supposed to be as fast for population health as it is for clinical research, for example, that somehow the bench to bedside is supposed to set the metric for timelines for changing health inequities in the population. Secondly, they're spending a lot more time doing those impact statements about what the research is than they actually get to do some of their research. So figuring out what the balances of incentives there, let alone the incentives that we're supposed to move to an entrepreneurial system even more that we have, that somehow we're supposed to make money off of the work that we do in public health, that's not necessarily, that actually flies against the history of how public health itself has advanced. Not that it will necessarily always be money losing, but it's not a money-making venture. So I think if we don't have these frank discussions that are fundamentally tied to questions of A, health equity and inequities, and B, the biological timescales on which different kinds of things change in populations, the removal of history from understanding the current place that we are. For example, so much research in the US says absolutely zippo about Jim Crow, and yet it's a lived reality in the population that we have. We have a problem there. So I think that these are really important questions that are being raised, but we have got to keep the health equity and the understanding of population health and the biological timescales involved and timeframes to have this be meaningful, let alone what's going to happen within academia. And so I'll stop there because I'm just wondering how you each would approach that question of how you think about the health equity dimension to what you're saying and how you think about the timescale dimension to what you're saying of where you want to have research be impactful.
Yeah, thank you for that. Anybody who wants to take that on?
Be happy to start. I think the points you raise are incredibly important, Dr. Krieger. I think that the issue of health equity is really key. And for instance, the 50,000 or so new infections a year, the makeup of that has changed so much over time. And we've watched incidents go down among persons who inject drugs, and the epidemic among young, especially young black gay men, go up dramatically over time. And I think as we kind of would slide the window of history along that timeline, we would talk about the effects of research in different ways and what's the next thing that we need to do in different ways. So I totally agree with that point. And I think also I agree with the issue of looking at short-term and longer-term impacts of what we do. For instance, in Baltimore, there's a really serious epidemic among young black gay men, and we need to think about short-term impact. For instance, in the updated national AIDS strategy, it asks us to reduce new diagnoses, but the epidemic of undiagnosed young black gay men is so severe in Baltimore that actually I want diagnoses to go up over the next 6 months so that we can make them go down over the long run. And I think balancing these long and short-term timeframes is really critical, so thank you.
We have time for one or two brief other comments. Lisa?
I agree. But I just want to underscore your point about the frank conversations, and sometimes those are difficult conversations for folks to have, particularly with the history of racism and all of these fundamental issues. But the conversation seems to be more, this is again my optimism shining through, I see a different conversation now in Washington, and Washington is a bubble, but understanding bias in ways that we haven't talked about before. So again, I think let's create more tables where we can have those honest conversations.
Okay, that's actually a great way to not to end this conversation today, but to acknowledge that has to keep going forward in that spirit. Let's thank this wonderful panel for this.